1% 2-year survival, as opposed to good match controls of 23%. So nobody else is. The English are taking this on a little bit, but Australia and New Zealand certainly haven't, and acute alcoholic hepatitis is still a contraindication. So what about the psychosocial issues? I've just summarised this in 2 slides. I had to review all this for a meeting I had to give at ASLD a few years ago, and it's quite interesting. There's no doubt that there's a correlation between psychosocial issues in patients waiting for liver transplant and low economic status. But there's definite evidence of discrimination in the data with regards to listing and socioeconomic status. However, there's evidence that socioeconomic status alone does not predict post-transplant outcomes. And all the centres make decisions on psychosocial grounds. All centres, and one study showed that when you start to do that, it takes an enormous amount of time. One last comment before finishing. My slide's just finished. Is methadone. Methadone shouldn't be by itself an automatic ruling out of patients. They should be. We need to educate physicians and evaluate on a case-by-case basis. The major problem with people on methadone maintenance is the pain control after transplantation. So, are there any absolute exclusions? Well, I think the only absolute exclusions are significant extrahepatic disease which is not correctable by liver transplantation, and the increasing problem of significant coronary artery disease in that situation. Active HIV infection, not controlled, is other uncontrolled non-hepatic infection, continued alcohol and drug abuse, and poor social supports. People living alone in the community are probably the only exclusion criteria these days. We're much more relaxed about taking patients to transplant. And I'd like to acknowledge none of those people before, but I would still like to acknowledge my colleagues within the Australian New Zealand liver transplant community. Thank you.
That was great, thank you. Now we started a bit late, so we're running a bit late. Is there anybody who has any burning questions?
Things, but if it's background cannabis use, we don't ask.
Can I ask about age? What's your criteria about age? Because I guess we have all these healthy 75-year-old people now.
Yeah. So we don't have an age cutoff, but we haven't transplanted anybody in their 70s. Now that's just referral. I think the people that we would transplant in their 70s are the PBCs. I don't think we'd transplant NASH in the 70s. I think age would come in, but I think cholestatic liver disease, particularly PBC and maybe even PSC, we wouldn't exclude.
With the diastolic cardiac,
Yes. Well, the cardiologists find it really, really hard to diagnose. So people who, I'd really like the cardiologists to start to do cardiac MRIs, because I think that's probably the best way to pick it up. But the routine, I do get into trouble occasionally with patients who have major cardiac.
Yeah, I wasn't quite sure either, but there you go.
So we're going to try and stick to 20 minutes.
Okay,
Or less if you can.
yeah, okay, I'll do my best. So they gave me 45 minutes to talk on this in Wellington 3 years ago. That was obviously more than anybody could bear, and it's been, I can quite understand that. So I'm going to just try and outline what are the long-term complications after liver transplant, discuss driving those complications, strategies for reducing complications, particularly optimization of immunosuppression. Liver transplants were managed with steroids and azathioprine. It was really only when cyclosporin was introduced in the late 70s that things started to turn around. And Jeff has already shown you this slide, which is the local data, shows era after era how outcomes have improved. And we've now got patients, so certainly more than 50% of patients are still alive transplant. And that's because immunosuppression is better, but immunosuppression, is a double-edged sword. So, I'll just put it back. So certainly good at controlling rejection, but unfortunately you get all the adverse effects along with that. And it's definitely a balance trying to control rejection, but at the same time minimize the adverse effects. And certainly the adverse effects largely as a result of immunosuppression, or at least exacerbated by immunosuppression, are highly prevalent in the transplant population. Of course, Mr. Trump is not a transplant recipient, but I think he has a lot of the characteristics you'd expect to see in a long-term transplant recipient. I don't think bad hair is an adverse effect of transplant, no. And he certainly wouldn't pass the psychosocial for a transplant, not in New Zealand. I'm not going to talk about rejection. I think rejection, it still occurs, but it's really not that much of a problem. Looking at the New Zealand registry data, less than 1% of patients transplanted were retransplanted for rejection. About 1.5% died as a result of graft loss due to rejection. So it's not an issue. And so I'll talk a little bit about recurrence of the initial liver disease at the end. So I'm going to talk about renal insufficiency first. And this is data. It's quite old data from 2003, but it's a huge number of patients. This was nearly 37,000 liver transplant recipients that were analysed by Ojo et al. And they found that after 5 years, 20% had CKD stage 4, and that 5 to 8% of all patients had end-stage renal disease that required dialysis or renal transplantation after 10 years. And apparently 1% of all renal transplants in the US are carried out because of post-liver transplant renal failure. And interestingly, liver's up the top there, just behind intestine transplant, but really, compared to others, it's really leading the way in terms of the prevalence of chronic renal disease. And it does have a significant effect on mortality. So the odds ratio of death over 4 times in the patients with chronic renal failure compared to those without. And 10% of deaths 5 years post-transplant are due to renal failure. It's multifactorial. There are certainly pre-transplant factors. So as you'd expect, if you've got renal dysfunction you're more likely to have it afterwards. Perioperative acute kidney injury, preoperative hypertension and diabetes, and of course these are big factors post-transplant as well as in the non-transplant population. Obesity increases the risk, but probably the most important factor is calcineurin inhibitors, so cyclosporin and tacrolimus. And it's thought to be the cause of renal dysfunction in about half of liver transplant recipients. And there's a definite difference in the pathophysiology early and late. So early on, it's afferent arteriolar vasoconstriction, so reversible with dose reduction. But as time goes on, then you do get this more permanent CNI-induced arteriolopathy. Cyclosporin is perhaps a little bit worse than tacrolimus, but the difference is marginal. So most of our patients, really, the emphasis is on trying to moderate tacrolimus, that's our primary immunosuppression, as much as possible. And we have this sort of fairly loose guidelines as with regards to levels at a particular time after transplant. Of course, it has to be moderated according to patient's history of rejection and other drugs that they're on. For those patients that do develop CNI-induced renal dysfunction, to what extent can we minimise the CNI? So there's a lot of data on this slide, but the bottom line is, certainly there's good evidence that if you use a regime with low CNI from the start, that actually it does benefit renal function and without a significant effect on acute rejection. We tend not to do that. I think that's because the mycophenolate, which is the second immunosuppressive that's used, does tend to have significant side effects in transplant patients. What about introducing it late? And in all these studies, there were more than 5 years, or certainly more than 4 years before there was a switch from a CNI-only regime to either no CNI or low dose in combination with mycophenolate. And certainly most of them did show that there was an improvement in GFR. But the payoff is really very significant increased rates of acute rejection. So, I mean, it is something that we do, but again, it's about patient selection, selecting patients with a low risk of acute rejection. Recently published systematic review of MMF showed that otherwise, in terms of other adverse effects, it did seem to reduce the rates of new onset of hypertension, didn't have any effect on diabetes. They suggested no effect on leukopenia, which is, I don't think, what we see. We see quite a lot of problems with leukopenia, but increased risk of thrombocytopenia, and certainly we see the diarrhea. What about other agents that you may be able to substitute in place of CNIs? So the mTORs, mammalian targeted rapamycin inhibitors. So sirolimus is what we have available in New Zealand. Different mode of action to the CNI, so you don't get the CNI type of nephrotoxicity. Can cause glomerular damage, so it's certainly not completely blameless in terms of the kidneys, but that's principally patients who have proteinuria. This recent meta-analysis again suggested that there was an improvement in renal function. That was more profound if you started early rather than late, but again, there's a payoff. Increased risk of acute rejection, relatively modest, but also significant side effects. So hyperlipidemia, mouth ulcers, proteinuria I mentioned. Also associated with delayed wound healing, so certainly it's got a black box from the FDA in terms of early post-transplant, and that can cause issues even in patients late after transplant if they need surgery. So, but again, you know, it's something that we do use in an appropriate patient. Okay. So what other strategies can we adopt for preserving renal function post-transplant? Well, certainly aggressive control of blood pressure. So usually aim for 140/90, but the American Society of Nephrologists say if you've got CKD and a urine albumin over 30 milligrams a day, then 130/80. And similarly, same target plus use of angiotensin receptor blockers or ACE inhibitors in diabetics with proteinuria and CKD. Optimal control of diabetes. Obviously, you need to regularly increasing number of patients being transplanted for NAFLD and NASH. That's likely to increase. Diabetes, about 15% pre, 30 to 40% afterwards, but actually even pre, 60 to 80% have impaired glucose tolerance. As you'd expect, more common in patients who have increased BMI. It seems to be more common in patients who receive a steatotic graft as well. Hypertension, relatively uncommon pre-transplant, again very common post, mainly driven by the CNIs. Hyperlipidemia, uncommon, but very common post. Obesity, I'm going to talk about a little bit more detail. So everybody gains weight post-transplant, regardless of what your starting weight is. Interestingly, the obese patients actually lose the most post-transplant, but by the time you get to 1 year out, their weight gain is the same as patients who are underweight or normal weight. And a median weight gain, 5 kilograms at a year, 9.5 kilograms at 3 years. And while only 45% of patients are overweight or obese at the time of transplant, 3 years out, 67%. And there's interestingly no significant association between weight gain and gender or corticosteroid duration, CNI type, or pre-transplant obesity. So really, it's restoration of good health. Obviously, we've been pushing a high-calorie, high-protein diet in many patients before transplant, and they just obviously carry on after transplant. And as you'd expect, you know, given the weight gain, a pre-liver transplant BMI over 30 is a strong predictor of still having a BMI over 30 at 3 years. And unfortunately, so this is some local data that Ming Han, Lim and David all collected, as I'm sure is most transplant programs across the world, BMIs are steadily climbing. So that's in a relatively short period of time from 28.7 to 30.6 in our unit. And of course, if your BMI is increasing, your risk of other components of the metabolic syndrome increases. What are the consequences? Well, certainly in terms of cardiovascular disease, patients with metabolic, so transplant patients overall have a much higher risk of cardiovascular events, death from cardiovascular events, and really a short time to the first cardiovascular event. But in patients that have metabolic syndrome, then it's way higher, so they're very much higher risk. So management, so certainly usual weight loss interventions. I think actually bypass post-transplant, but there's probably maybe more mileage in patients at risk in combined liver transplant and sleeve gastrectomy and kidney disease. Calcium, certainly in our unit, calcium channel antagonists are first line. Early post-transplant tends to be a low renin-angiotensin state, so ACE inhibitors are not. This is Jeff McCorn's data. The exception is skin cancer, and in fact that's by far and away the most common de novo malignancy in liver transplant patients is skin cancer, but non-melanoma skin cancer. I'll just skip over that. So just say, so certainly patients transplanted for, so smokers or transplanted for alcoholic liver disease, very significant increased risk of esophageal and head and neck cancers. So I'll just skip over that as well. So skin cancer, I mean, we find it very difficult in Auckland to get the dermatologists to see our patients. Even patients who've had multiple tumours, they seem somewhat reluctant. Normal screening, so annual colonoscopy in patients with PSC and IBD. Certainly high index of suspicion for head and neck cancers, and otherwise adherence to normal screening population, screening advice. Disease recurrence, so a broad range of risk of disease recurrence. Now, certainly Hep C, obviously, we know that there's almost universal reinfection of the graft, but the rate of graft loss varies markedly. So although, for instance, in PBC, there's a reasonable rate of recurrence, graft loss is extremely uncommon, much more common in PSC. Management, so at least we've got some treatment for Hep C now. I mean, that's certainly the disease with by far and away the highest recurrence and the highest rate of graft loss, so hopefully that's going to be much less of a problem. Hep B is effectively under control with our current antivirals, and we're currently doing a trial switching patients to TAF. Natalie's going to tell us about how we can stop our patients returning to alcohol, or at least select the ones with a low risk. NASH really is addressing risk factors. HCC is largely selecting patients with a low risk of recurrence. There has been interest previously in using a sirolimus-based regime and some evidence that there may be lower HCC recurrence, but actually a recent meta-analysis in a reasonable number of sirolimus-exposed patients didn't really show any difference, except in men over the age of 55, there may be some benefit. Autoimmune hepatitis, probably low-dose prednisone is advisable. PBC, PSC, not really much that we can do. So we've now got patients surviving a long time, which is obviously good, but it does mean that their chances of developing immunosuppression associated with adverse effects is much higher. So we need to always bear that in mind and really try and optimize immunosuppression and increasingly manage metabolic risk factors. Thank you. I'm sorry. Went on a bit. Any questions?
The FGM data was certainly alarming when it came out. Gary Jeffries was our understanding doing the analysis of the Australian New Zealand experience and finding much less chronic renal failure, probably less than 10% in the long term. And I think the North American practice, there are no surgeons in the room, probably reflect that a lot of long-term patients in America were looked after during that period with surgical follow-up.
Right.
Just a bias.
Thank you.
Natalie Sky has recently joined our team in liaison psychiatry, working alongside us at the Transplant unit and has a great deal of expertise in alcohol and drug services. She's going to talk to us today about the 12-step program. So, I think.
All right, yes, so excuse my croaky voice, I'm just recovering from a bit of a bout of a cold. And please let me know if I'm not talking loud enough, because I also have blocked ears as well, so I can't really judge the volume very well. Yes, I'm a psychiatrist. I'm feeling a little bit out of my comfort zone talking to a group of very expert gastroenterologists. But really just, I haven't focused specifically on liver transplant. I've looked more particularly just at alcohol use disorders in general and how they might be able to be helped within your specialty. So the 12 steps. Step 1, know the scale of the problem. And I'm not going to cover this because you know this information far better than I do, but the burden of disease related to alcohol and liver disease. Somewhat frightening worldwide statistics as well in terms of numbers, burden of disease, deaths, number of deaths in New Zealand, and also the increasing evidence about cancers and alcohol, not just liver, but a wide range of cancers. In particular, female breast cancer has quite a strong association with even quite small amounts of alcohol, so interesting. What about numbers in New Zealand? Actually, the most recent information we have is quite old. It's about 10 years old. It suggests the prevalence relatively low. So in Australia, their population surveys are much higher, closer to 4%. Whether that says something about Australians, I'm not sure. But when they complete the audit, which I'll talk about in a little bit more detail, actually the numbers are probably closer to 2.2% across the population. So for a city of Auckland, where I'm from, what does that mean in terms of numbers that we might expect with alcohol dependence? That's a fairly large number of people. Okay. I'm not going to talk about that again. I thought that was a slightly concerning statistic as well, the last one. As we're all driving home today, 17% of people who've drunk in the last year have driven at least once under the influence of alcohol. So nice to think about that as you're behind the wheel of a car. And who do we see in CADS in Auckland? We primarily see people with alcohol use issues, and actually the numbers for other substances are much smaller. My next step 2, is to actually use the tools available, and there's lots and lots of research that suggests, not amongst the gastro team and the liver teams obviously, because you all take exceptional alcohol histories, but generally in health fields, even in mental health, it's often actually not done that well. So my suggestion, one of my recommendations, is to consider using the audit in your patients in clinic. And I've got some audits there for you to hand around if anyone wants to do one to see what their audit score is. Anyone who's consumed any alcohol in the last 12 months will have a positive score, so don't freak out. But essentially it's useful because it gives you a spectrum score. You know who's low risk, who's risky, who's high and harmful risk, and also if someone's scoring above 19, there's a strong correlation that they're probably alcohol dependent. And this is data from CADS showing a linear relationship between the vertical axis there, which is the severity of alcohol dependence score, and their audit score. So these are people coming into Pitman House for detox, and that's their audit scores when they come in. So obviously we're seeing the severe end of the spectrum. And then this is slightly less evidence-based, but I think it's always quite useful to actually ask people about blackouts. It gives you quite a lot of information. You probably either read or seen this movie. So Emily Blunt plays a woman who has fragmentary blackouts from severe alcohol dependence. It is actually really common amongst the general population. So 35% of people in a paediatric residency program in the States actually had a blackout, and 33% of first-year medical students in a medical school, not across the board, had blackouts. But the most important thing is it's the chronicity. So people who are having regular, frequent blackouts, generally drinking more risky and more likely to have a significant problem. And it's the number of relatives that people have with alcohol dependence that actually predicts the chronicity of their blackouts. I think it's useful to ask about age of first use as well. This is a really good book written by this woman here who had a severe alcohol problem in her actually teens right through to her 30s, and I'm not going to read it out, but she had a a description in there of her first use of alcohol at the age of 6, and then her use, surreptitious use in the family home from the age of 7. So it's definitely worth a read. Right. I think I must have scratched. Oh, yes, step 3, know the limits. So when you're talking with your patients about alcohol use disorders, it's actually important that you know what you're going to be advising them. And I've asked medical students in the last year, I've taught every cycle of students who've come through this question, what are the low-risk drinking limits? And rather concerningly, only one group actually knew. So I'm not going to ask this group because you will all know, but it's a lot lower than everyone is aware. So it's reduced in the last few years to no more than 10 standard drinks a week for a woman and 15 for a man, and at least 2 alcohol-free days per week. So, that's useful to have that information tucked up your sleeve. Step 4, make the diagnosis. So actually really clearly diagnose whether someone has alcohol dependence. And you only have to have 3 criteria in the last 12 months to meet the threshold. And, I'm missing a bit there. But the most important thing is that you don't actually have to experience withdrawal or tolerance. You can have other symptoms that meet the threshold. And step 5 to 10 is about treatment options. So this is what I'd be thinking about for people who come to see me who have severe alcohol problems, because there are a lot of options. The first one is to consider a brief intervention, so someone who has risky drinking, so an audit score. I've noticed no one's doing an audit, but you can pass them around if you'd like. There's 30 of them, so enough for everyone in the room. This is really, there's a good structure for this, which is using motivational interviewing, where you can personalise feedback, and having an audit score to feedback to someone's actually really helpful. With selected people, I would actually provide people with their LFT results and use that as a therapeutic tool as I'm working with them over time to talk about what's happening, how that reflects the changes they're making. Emphasise that's their responsibility. Give non-directive advice, which is very hard to do as a medical practitioner when you know stopping alcohol consumption is the key intervention. Give them a range of options. Be empathetic and emphasise that it's them who are going to make the change. Okay, I'm missing a few slides in this, I'm sorry about this. And the next step you might consider is referring to specialty services. Most people who come to CADS refer themselves, so you can see that's the vast majority, or from the justice system. Actually, very few referrals come through the health sector. We're happy to receive referrals as long as people have consented, so useful to think about that and talk about that with patients. Now, the thing about alcohol and drug services is that they all use this harm reduction approach. So rather than the abstinence approach that we generally would want for patients with liver disease related to alcohol use, they're looking at a range of options. And in CADS in Auckland, we would look at groups of someone, one-to-one counselling, which can be useful if people have cognitive impairment or encephalopathy, so that you can tailor the treatment a bit more. Detoxification if necessary, and pharmacotherapy, which I'll talk a bit more about shortly. And as I say, there is that slight tension between, the medical drive for abstinence and the harm reduction approach of CADS. It's been very successful in certain areas, in particular needle exchange programs and safe injecting practices. This is a slightly tongue-in-cheek, kind of Marilyn Monroe-esque view of harm reduction. But more and more, I think services are realising that abstinence has always been part of harm reduction, but that it needs to be offered as a standalone treatment option. So in CADS in Auckland, for example, we have an abstinence-based program, 12 steps, and people can enter that for a year-long intensive treatment as an outpatient. So Alcoholics Anonymous, some of you may have seen this TV series. It's a comedy series. It's actually quite a good depiction of 2 people in long-term recovery from alcohol dependence. And they're engaged in Alcoholics Anonymous. So it's been around for a long time. They talk about alcoholism, which is not a term used so much in the addiction field anymore, but they strongly identify themselves as alcoholics. You only have to want to stop drinking to join, and they very much emphasise the fact that it's not a religious affiliation. Despite that, though, this is the 12 steps, and read out all the bits of the 12 steps that emphasise God or spirituality. So it's not for everyone, and a lot of people react quite strongly to some of these aspects of the 12 steps. And does it work? So there's a lot of really mixed evidence out there in the literature, and it's a bit hard to tease it all apart. Project Match, which was one of the key research projects looking at treatment outcomes, showed that it was equivalent in the short term and possibly better in the long term for people. Although the Cochrane review in 2006 were pretty equivocal about it. This more recent paper in 2009, which I like the title of, Faith Meets Science, showed a good response, abstinence rates up to twice as high, and that there was a dose effect, essentially. The more people went, the more they were likely to do well. So residential treatment, and that's something that maybe doesn't get considered a lot, but is actually actively encouraged for a lot of the people who present to addiction services. It's recommended only for the most complex clients or patients, and I'm sure you would be seeing a lot of people in your clinics who have complex medical, psychological, mental health, social comorbidities. The problem is there's no real standardisation in the approaches used by these programs, and not a lot of research into treatment outcomes. The most recent one, the NHS, when they're driving to save money, wanted to figure out how cost effective it was, and they found that 30% of people who complete residential treatment exit it after finishing it and enter what's called recovery, whatever that may mean. This is data from the Salvation Army Bridge program. So they last year wanted to know if their program's effective in treating people with alcohol or substance use issues as well. So the black is when they came into the program, how many days out of the last 28 they were drinking, and the striped is at 3-month follow-up. So you can see, obviously, there's been a shift, although this is only about days of drinking in the last days of use in the last 28 days. They don't report on abstinence or achievement of abstinence, which is kind of interesting in and of itself. And then the next step to think about might be compulsory treatment, because people can be treated compulsorily. It's a difficult process to undertake. And the rate limiting step is that you actually have to have a bed available at a certified institution before you can even make an application. And in the middle to Upper North Island, there's 4 beds set aside for people under the Act. So given that they're there for up to 2 years, the waiting time for a bed is 6 to 12 months usually. So it's pretty hard. It is in the process of being changed. So the new legislation, the SAC Act bill, or the Substance Addiction Compulsory Assessment Treatment Act, it's currently in its 3rd reading. So it should be passed next year, and it will come into effect in the next 1 to 2 years. Right, so pharmacotherapy, which may be something that you may be most interested in, perhaps. It's currently got evidence as an adjunct to psychosocial treatments. Use of medications alone is not advocated, and the guidelines from the British Association of Psychopharmacology says it should be offered to everyone with dependence. So these are the medications that are currently approved by the FDA for treatment of alcohol dependence. These are the ones that are available in New Zealand. And in terms of I'm not going to go through them in detail just in the interest of time, but in terms of the treatment of these, the use of these in liver disease, there's a black box warning about hepatotoxicity for naltrexone. Although it's rare, it's reversible usually, and it only generally occurs when people are using excessively high doses. So normally the maximum dose is 50. This has generally been reported for people taking more than 300 milligrams a day. But the current FDA advice is to avoid it if there's acute hepatitis or liver failure. So, it may be contraindicated in a lot of the patients you see. Disulfiram, it's been around for a long time. It works by blocking aldehyde dehydrogenase and building up this substance here, which causes horrible reactions. So you get awful facial flushing. That may not look very bad, but it's incredibly unpleasant and associated with a whole lot of other physical symptoms. So it's a negative deterrent. And what about this in liver disease? Generally not considered a safe option. Although, excuse me, the changes that you get are relatively mild, but it happens in about a quarter of patients. And it's got a fatality rate, if it occurs, of 10%, which is quite high. I thought I'd briefly mention baclofen. A couple of minutes left? Okay. Because there's a lot of discussion about that. It's not approved for use in New Zealand in alcohol use disorders, but it is the only medicine that's got a randomised controlled trial in patients with liver disease, with cirrhosis. And it certainly improved outcomes for them at the end of the study period. But they used very low doses compared to what's being advocated on the internet by lots of people. There's a large movement on the web, people sharing information about their own, N of 1 studies. And the thing for CADS is, and why we don't generally prescribe it or recommend it, is that it's lethal in high overdose. And we've had a number of patients who've died as a result of intentional overdose from baclofen. I just thought I'd mention thiamine briefly. Everyone knows to give it in hospital, but there's no evidence for use in someone who's got a normal diet. But if someone has decompensated liver disease, they should be receiving prophylactic oral thiamine if they're still drinking. And the other thing is that there's evidence that no more than 10 milligrams of any single oral dose is absorbed. So the way we prescribe it in CADS is 50 milligrams multiple times a day, because even if you give someone 100 milligrams, they're still only going to absorb about 5 to 6 milligrams of that. And step 11, expect challenges. So relapse, and that's what you were mentioning, Dominic. Yvonne Fullerton, one of my colleagues, presented to this group some years ago about relapse rates post-liver transplant. This is the DiMartini study figures up here. So, the relapse rates are significant even in patients who have a high degree of follow-up, who are, motivated and who have lots of support from multidisciplinaries. That it's a chronic condition, like all the other chronic medical conditions, type 1 diabetes, hypertension, asthma, and that relapse rate, so deterioration in clinical state, needing admission to hospital, complications, are actually really similar across the board. So it needs lots of addiction expertise, mental health professionals, which in this case was psychologists, and really enhancing someone's holistic management in addressing both the medical side of things, comorbidities. So we had that brief